Hi, let's meet Arav. Like many of us, he's preparing for his exams. He decides he will really prepare well day and night. And after hours of studying, however, something goes wrong. His eyes feel heavy, tired, and strained. He notices that when he looks away from the screen, the distant world now seems blurry. Near things are fine, but far ones, not so much. He really wonders what exactly is going on. Did he just become myopic, or is this something else? Well, this isn't just myopia. What Arav is experiencing may be a common but often misunderstood issue of accommodation. So hello and welcome to Insight Ophthalmology. I am Dr. Amrit, welcoming you to another lecture. Today we shall be discussing about the accommodative anomalies associated with excessive accommodation, namely the accommodative excess and accommodative spasm. And also we shall throw light on pseudomyopia as well. At this point, I would request you to subscribe to our channel if you haven't done it already. So now let's get started. First of all, let us try figuring out what exactly is the difference between true myopia and pseudomyopia. True myopia is basically related to increased converging ability of the eye, or in other words, increased power of the eyes. This excessive convergence basically renders the rays which are coming from infinity to converge more and focus in front of the retina instead of focusing on the retina. That is true myopia, and this happens either because of the increased curvature of the cornea, wherein it is known as the curvatural myopia, or it could be because of the increased curvature of the lens, then it is known as the lenticular myopia, or it could be because of the increased length, axial length of the eyeball, and then it is known as the axial myopia. However, when we are talking about the pseudomyopia, we are talking about the myopia which is occurring because of some problem in accommodation. Okay, so let us try to understand what exactly is accommodation. Normally, when we are looking at a far object and if we do not have any refractive error, that means if we are emmetropic, the rays of light which are coming from infinity, they are going to fall and focus exactly on the retina. However, when we want to focus on an object which is present at a near distance, say at 30 centimeters, 33 centimeters, the rays, instead of being parallel, they are going to become more diverging. And these diverging rays then are going to focus on the retina only with the help of the lens. And let us see what happens during accommodation. During accommodation, a muscle which is present in the ciliary body, known as the ciliary body muscle or the ciliaris, basically will undergo contraction. As the ciliary body or the ciliary body muscle basically undergoes contraction, it leads to loosening of the zonules or slackening of the zonules, which basically attach the lens to the ciliary body, and this slackening of the zonules leads to increased curvature of the lens. So in simple terms, the lens which was initially flatter while looking at a distance will now start to become more and more fatter or thicker. As the lens becomes more fatter because of accommodation, this leads to increased converging ability of the eye, or in other words, increased power of the eye, or it leads to what is known as accommodation. This increased power or this increased focusing ability will now allow the rays of light which are diverging from a near object to fall exactly on the retina. And this is the mechanism which helps us to focus the objects which are present near to us. This is known as accommodation. And in pseudomyopia, it is the problem arising because of accommodation, because of excessive accommodation, that the lens becomes thicker or that the lens acquires excessive power, and not because of the anatomical problems that we saw in case of true myopia. So that's a very basic difference between myopia and pseudomyopia, and we'll talk about it in detail in this video. So as I told you, basically in accommodation, the ciliary muscle is first going to contract, and as the ciliary muscle is going to contract, the zonules which are attaching the ciliary body processes to the lens are going to relax, and as they relax, the lens is actually going to fatten up or is going to basically increase its anterior posterior diameter, and this leads to increase in the power of the lens, and that is what is accommodation. So as promised, today we are discussing the anomalies of accommodation associated with increased accommodation, and these are of two types: accommodative excess and accommodative spasm. So let us first try to understand what exactly is the difference between accommodative excess versus accommodative spasm, because as I told you, both of them are associated with excessive accommodation. Let's try to understand this using Arav's example. Imagine now Arav is seated at his desk, leaning into those books and laptop with laser sharp focus. It's like he's pedaling a bicycle continuously to look at something up close. Here, the bicycle is akin to accommodation and his legs and the pedal are akin to the ciliary muscle. It's been too long that he has been constantly bicycling, using that effort to go uphill, which what I mean to say here is that he's constantly using his ciliary muscle to look up all that close. Now say suddenly he arrives on a level ground. What happens? His legs will take a while to stop pedaling. Similarly, say Arav decides to finally take a break, but his ciliary muscle has gotten so used to going on that he finds some difficulty in stopping. The brain wants to stop, but the ciliary muscle has a habit now. It takes time to let go. Okay, so next time when he sets to do any near task, it is going to contract even more than what is required. This is known as accommodative excess, where the accommodation is greater than what is required and also there is difficulty in relaxing that accommodation. Now let's try to understand accommodative spasm. Now say suddenly Arav's bicycle chain suddenly gets stuck. He's trying to stop, but the wheels are going to keep on spinning. So he realizes that he has lost control over the pedal. This is spasm, my friends. So in spasm of accommodation, it's not just a habit, it's a lockup. The ciliary muscle is going to go into an involuntary cramp like a muscle spasm. And here, not just the ciliary muscle, the entire near reflex triad is going to get activated. The pupils are going to constrict, the convergence is going to kick in. So it's a full-blown misfire and it doesn't get resolved on its own. This accommodative spasm needs clinical intervention. Let's look at the definition. In accommodative excess, it's basically a sensory motor anomaly characterized by persistent over-focusing during near tasks, and also there's an inability to relax the accommodation readily. Also, there is reduced accommodative flexibility or stability. However, when we talk about accommodative spasms, here the ciliary muscle remains contracted post near work. So even after the near work has ended, the ciliary muscle remains in that state of contraction. This leads to pseudomyopic refraction. More about this in a while. And it is associated with other components of near reflex triad, that is the pupillary meiosis and convergence spasm. Let's summarize this in a form of a table. So in accommodative excess, it's basically a voluntary habit. Here, whenever the patient looks at a near object, the muscle tries to contract more. There's excessive accommodation and this excessive contraction of the ciliary muscle. However, this muscle takes some time to relax. It does relax, but it takes some time to relax. It is not associated with convergence or with pupillary reaction. However, in spasm of accommodation, it's more of an involuntary cramp. The muscle here doesn't relax without any intervention and it is associated with the spasm of near reflex, that is convergence, and meiosis, that is constriction of the pupil. Now, it is this accommodative spasm that causes pseudomyopia. So what did I tell you? Pseudo means false and myopia is myopia. So true myopia is because of the anatomical problem. Either there is an increased axial length or there's increased curvature of the cornea or this increased curvature of the lens, right? That is known as lenticular myopia. However, myopia arising because of excessive accommodation, and we know that accommodation ultimately is going to increase the curvature of the lens, rendering excessive power to the eyeball. That myopia is known as pseudomyopia. This is transient myopia because of ciliary muscle spasm, and usually the range is minus 0.50 diopters to 2 diopters. However, usually many cases actually come with even values more than minus 2 diopters. However, this is reversible with cycloplegia. Now, studies suggest that this transient myopia is not harmless. It can progress to axial myopia if untreated, with 21.1% converting within 6 months in high-risk pediatric population. So you can go ahead and study this multicentric study on the conversion rate of transient myopia to permanent axial myopia. And the pathophysiology behind accommodative spasm. What really happens which overdrives our ciliary muscle? To understand this, we have to understand the near triad reflex and its center. The parasympathetic nucleus, which is responsible for accommodation, and for the near triad reflex is the Edinger-Westphal nucleus, which is located in the midbrain. The Edinger-Westphal nucleus basically sends impulses via the oculomotor nerve. It reaches the ciliary ganglion here, and from the ciliary ganglion, the impulses pass via the short ciliary nerves to the ciliaris muscle, which is responsible for the accommodation. Okay, now whenever we are doing constant near activity, that leads to parasympathetic overdrive. This parasympathetic overdrive leads to constant stimulation of the Edinger-Westphal nucleus and ultimately leads to prolonged accommodation, ciliary muscle spasm, and pseudomyopia. Also, these nerves are also going to supply the sphincter pupillae muscle, leading to meiosis or contraction of pupil. They supply the medial rectus, and medial rectus overactivity leads to convergence spasm. So as I told you that biomechanical fatigue of more than 4 hours per day near work reduces the accommodative reserve by stimulating accommodative spasm. Now, neurological triggers also play a significant role. Head trauma is seen in 27% of the cases of accommodative spasm. Encephalitis, trigeminal neuralgia are all the other conditions which could be associated with accommodative spasm. Also, stress-related autonomic imbalance could be one of the causes for accommodative spasm. Now, you might think that stress usually triggers the sympathetic nervous system, which is associated with relaxation of the ciliary muscle. This happens in acute stress. So, acute stress does trigger the sympathetic nervous system. But when someone is suffering from chronic stress, the sympathetic nervous system can also burn out, and at this time it is the parasympathetic activity that takes over, and this is something which also explains the vasovagal fainting that occurs in acute severe stress and also in some acute on chronic stress conditions. Here the vagus activity basically takes over the sympathetic tone and leads to the conditions like vasovagal fainting and also accommodative spasm. Another condition which is responsible for accommodative spasm is the latent hyperopia. Now we know that in hyperopia, the rays of light are basically going to focus behind the retina. So young hyperopes, usually who have about +2 diopters to +4 diopters, they often use their accommodation to overcompensate. By accommodating, they try to bring these rays back on the retina. And this overcompensation ultimately can lead to overaccommodation and accommodative spasm. There are some drugs which can also induce accommodative spasms. These are morphine and sulfonamides. If you look at morphine, morphine basically enhances the parasympathetic tone via the mu-opioid receptor. On the other hand, the sulfonamides, they inhibit the acetylcholinesterase enzyme, the one which is responsible for breakdown of the acetylcholine, primarily a parasympathetic neurotransmitter. This prolongs the acetylcholine action at the neuromuscular junction, leading to accommodative spasms. Alright, after understanding the pathophysiology, let's talk about the clinical presentation of these patients. First of all, let's discuss about the symptoms. So these patients are going to present with variable visual acuity on the successive examinations. Also, they will have blurred distance vision, especially after the near work. Most of them are going to complain of frontal headaches, and the prevalence of frontal headaches is about 78%. They will have sensitivity to light, that is photophobia, and also asthenopia because of the constantly active accommodation. When we talk about diagnosis, the standard test for diagnosis is cycloplegic refraction, and after cycloplegia, you are going to find about more than 0.75 diopters reduction in myopia in these cases. Also, on monocular estimation method of retinoscopy, you are going to find accommodative lead of more than 0.75 diopters. When you carry out the negative relative amplitude of accommodation and positive relative amplitude of accommodation, that is the NRA and PRA test, you are going to find decreased NRA and increased PRA. The negative relative of amplitude of accommodation basically estimates the amount to which you can relax a patient's accommodation. We know that in accommodative spasm, it is often difficult for the patient to relax accommodation. As a matter of fact, it is actually impossible, and therefore you are going to find decreased NRA in these patients. Positive relative amplitude of accommodation basically assesses the amount to which a patient's accommodation can be stimulated, and therefore these patients are going to show increased PRA values. Pupillary response, you will find miosis during distance viewing also. Coming to treatment, the first phase of treatment involves spasm resolution. The second phase is neural retraining, and then there are some adjunctive measures as well. So how do we relieve accommodative spasm in these patients? And the answer is cycloplegics. And here the star cycloplegic agent is atropine. It's available at various doses. 0.01% is the low dose and 1% is the standard dose of atropine. The onset of action is 60 to 120 minutes, and it has a long duration of action of about 7 to 14 days. Okay, now the 0.01% can be used as a nightly dose. However, this has been extensively studied in myopia control studies. 1% is the standard dose which achieves full cycloplegia. The only problem with atropine is the various side effects. It can cause blurred near vision, obviously, because you are actually preventing the accommodation, and accommodation is necessary for near vision, and therefore post cycloplegic treatment the patient is going to have blurred near vision. Another thing is the mydriasis, which is associated with atropine, that will cause sensitivity to light and it will cause photophobia. Now atropine is basically an anticholinergic agent, so antimuscarinic effect will lead to dry eye. This is specifically true for atropine drops or ointment which comes with the BAK, that is nothing but the benzalkonium chloride preservative. Okay, so again, one more cycloplegic agent is cyclopentolate. It is available as 1% to 1.5%. Duration of action here, is about 24 hours. However, it has a faster onset of about 30 to 60 minutes of duration. Comparable to atropine, you can see that it has about 63.5% efficacy versus only 36.5% efficacy. Now, home atropine, if you see, it's available as 2% to 5%. It's pretty similar to atropine, and it is of moderate efficacy when you compare it to atropine and cyclopentolate. It can be used in those cases where there's some sort of atropine intolerance. It does cause dryness, it does cause photophobia, however, they are of milder degree. Alright, so what you have to remember is you have to remember about atropine. So atropine is available in low dosage and also as standard dose. Now it's available as 0.01%. This is prescribed as a nightly treatment for 2 to 4 weeks, and the standard dose, that is 1%, can be prescribed either once or twice daily for a week, right? Now, this is used specifically for chronic accommodative spasm, and when you talk about the 0.01%, it has minimal side effects. But when you talk about 1% standard atropine, it comes with its side effect. Now, to prevent those side effects, it is better if you prefer a BAK-free solution or a compounded preservative-free version of atropine. Alright, then we have something known as the plus lenses. Now, we know that the plus lenses basically help in accommodation, and in a way they basically relieve the accommodative demand. Now, these patients who have accommodative spasm, once you prescribe them cycloplegia, they're going to suffer with blurred vision. So specifically for those cases who are struggling with near vision post cycloplegia, as a combination therapy, you can prescribe them plus lenses as a near add, and here the amount of plus lenses that you will basically prescribe will be about 0.50 diopters to plus 2 diopter, and the main function here is to reduce the accommodative demand and not to relieve the accommodative spasm. So that is very important to understand. Alright, so we talked about the spasm resolution. Now let's talk about the neural retraining. Now, principal thing over here is the vision therapy. In my previous videos on accommodation, I told you how to do various vision therapy exercises, and so here the tests the exercises or the vision therapy exercise that you can do is accommodative flippers and heart chart exercises. Another important modification which might be required is a behavioral modification, and here you tell your patient to follow the 20-20-20 rule. This 20-20-20 rule basically suggests that after every 20 minutes of near vision task, you should look at something 20 feet away for 20 seconds. Alright, now this is basically particularly advised to reduce the accommodative strain in cases that are linked to prolonged screen usage. Also, outdoor activity of more than 14 hours per week reduces the progression risk of myopia and to some extent also reduces the accommodative demand. Alright, finally let's talk about some of the adjunctive measures here. So adjunctive measures and supportive therapies basically aim at relieving the stress component that might be associated with accommodative spasm. So psychological support is important, stress management, counseling, and also in cases of psychogenic cases basically with accommodative spasm. After psychiatric evaluation, SSRIs also could be used. And about formulations, as I told you, use back-free drops for long-term safety. Compounded options must be preferred. A lot of other treatments are right now emerging. However, they are at the animal studies level. One is nitroglycerin and another one which is plant-based is Perilla frutescens. If you're curious to learn more about accommodation, what it is, how we test for it, and various anomalies of accommodation, we have got you covered. A detailed list of videos are available right here on the channel, and you can find all the links in the description box. If this video added any value to you or helped you understand something better, please consider sharing it with your friends. It really helps us grow and reach more people. And before you go, don't forget to hit that subscribe button and tap the notification bell so you never miss a video. That's all for today. Thank you so much for watching. Till then, take care and have a nice day.